Hi everyone, my name is Ev. Thank you for attending this presentation today, either live or online. And thank you for the BCAK for inviting me today for the National Kinesiology Week. I'll be presenting about the most common heart condition and implication on practicing kinesiologists in terms of exercise prescription. Before we start the presentation, there will be a bit of time at the end if you want to ask questions. You can email bemister@sfu.ca, so BEMISTER@sfu.ca if you have questions at the end. So she will keep her inbox open so we can answer a couple questions at the end. So the presentation should last from 42 minutes to 48. We'll see how it goes. So without further waiting, I'll just explain a little bit about my background and then we'll go into the presentation. So first of all, I did my bachelor's degree in kinesiology in Montreal, and my last year of my bachelor's degree, I went and did an internship at the Montreal Heart Institute where I started working with cardiac patients. And I decided I wanted to keep doing that, so I pursued to the master's degree again in Montreal, but at the University of Montreal. So there I studied continuous versus high-intensity interval training in heart failure patients. I kind of like research, so I decided to keep doing that and pursued to the PhD degree in kinesiology, gerontology at the University of Sherbrooke, but then I switched population and studied obesity prevention and management in postmenopausal women. So here I am right now. I live in Kitimat, British Columbia in northern BC. I work for a non-for-profit organization where I help with funding. I also do a bit of a consultant with the community and also doing presentation like I am doing right now. And I also keep publishing articles with a collaborator that I have at Wake Forest University. So I'm an adjunct professor over there. So enough about me. Let's dive into the presentation. You'll see that I have a bit of an accent. It might take a couple minutes for me to get warmed up, and then it should somewhat disappear and be a little bit less strong as we go along. All right, so as we mentioned a little bit earlier, so I'll be covering coronary artery disease, chronic heart failure, and the effect of those conditions on the exercise response. And then we'll move on to the initial assessment. So what do we need to assess before we prescribe a structured exercise program for these individuals? So why are we so interested in cardiovascular disease in the first place? Well, as you might all know, our population is aging, and we know that the prevalence of cardiovascular disease increases as we age for men and women. So there's a lot of conditions that are associated with cardiovascular disease that will benefit from what we call cardiac rehab. So I'll use this word a lot in the presentation, such as people having coronary artery disease and heart failure, which we will discuss a little bit. So coronary artery disease, which I will refer to as CAD, is a progressive chronic disease with endothelial dysfunction, vascular inflammation, and the accumulation of lipids within the inner lining of the coronary arteries, just as we see in the image right here. This is what we call atherosclerosis. You might have heard this word a little bit before. So atherosclerosis changes over time and results in the formation of plaques or lesions, vascular remodeling, and culminates in the obstruction of normal blood flow to the heart. So any lesion that reduces the normal diameter of the major coronary artery by at least 50% are considered clinically significant. And this is what will usually be responsible for myocardial infarction. Lesions that are more than 70% are also considered clinically significant and are associated with what we call ischemia and angina. So those are two words that I'll use as well in the presentation. So So any impairment or obstruction to the blood flow to the heart, secondary to the coronary artery disease, is referred to as what I just said, ischemia, and a complete obstruction is what we call the myocardial infarction. All right, so what does this condition do on the exercise response? Well, the myocardial infarction resulting from the coronary artery disease can alter an individual's cardiorespiratory and hemodynamic response to submaximal and maximal exercise as well, right? So it often, so basically we can observe a reduced level of cardiorespiratory fitness. It's estimated they have basically 50 to 70% of the level of fitness of age and gender predicted. So much lower than what we could consider a healthy individual, basically. They also have reduced oxygen transport capacity that is primarily due to a diminished cardiac output rather than a peripheral extraction of the O2. So in some individuals, a primary limitation appears to be the decreased contractile force of the left ventricle because of that ischemia that we've talked about a little bit earlier. So how you'll see that on the exercise response is that as the intensity of the exercise increases, you might not see the blood pressure that increases as well. You might see a decreased blood pressure response during the exercise. So that's how you'll be able to measure it. And in other, cardiac output may be limited by the restriction in the rise of the heart rate or the appearance of the angina symptoms, which will refrain from exercising at higher levels. So those are the effects of coronary artery disease on exercise. So now that we've covered coronary artery disease, we can move on to heart failure, which I will refer to as HF in the presentation. So you're likely going to see more and more HF patients in cardiac rehabilitation because the prevalence of HF continues to rise because, well, people live longer and also because survival from coronary artery disease improves. So you're going to most likely see more HF patients or individual in your practice. And also because the incidence rises dramatically as we increase in age as well. So what is heart failure? Well, basically, it's the inability of the heart to adequately deliver oxygenated blood to the metabolizing tissue. So patients with HF will have symptoms due to impaired left ventricular function. So a little bit like in the image here, so you see that the normal heart has a normal left ventricular size, and the heart failure heart has a dilated left ventricular size. So it may be associated with a wide spectrum of left ventricular abnormalities, such as, like I said, a dilated left ventricular, or also because of a reduced ejection fraction, which would be considered reduced if it's less than 40%. But some HF patients also have a preserved ejection fraction, which would be over 40% of ejection fraction. So we call them HF with reduced ejection fraction or preserved ejection fraction. But not only do we have to consider the ejection fraction in HF patient, we also have to consider if it's a systolic or a diastolic function, so dysfunction. So if you remember well your physiology classes, the systolic phase is when there's a ventricular contraction, so in HF patient it would be impaired, whereas the diastolic dysfunction is when there's an increased resistance in the filling phase of one or both of the ventricle. So basically, HF is a syndrome where there's objective evidence of cardiac dysfunction, as I've just described. And we can observe this at rest and during exercise. So the hallmark symptom of heart failure is breathlessness, also fatigue and ankle swelling. So basically, if we move on from that, saying that those are the hallmark of heart failure, well, what will that do on the effect of the exercise response? Well, there are a lot of central hemodynamic changes associated with heart failure. So central, peripheral, and ventilatory abnormalities will influence the exercise response in person with heart failure. But the primary concern, irrespective of if it's a systolic or diastolic dysfunction, like I've just explained, is HF causes a reduction in cardiac output relative to the demands of the work. So what will that do? You'll be able to observe that in the individual having shortness of breath. Like I said, that's really a hallmark of heart failure. Also, there will be peripheral abnormalities, such as abnormal redistribution of blood, reduced vasodilatory capacity, sorry, that's a hard word, abnormalities in muscle metabolism, which all will have consequences on the leg fatigue. So remember that when you're going to work with heart failure individual, shortness of breath and leg fatigue as well. So, the leg fatigue is the result of the inadequate blood flow to the skeletal muscle. So just as an indication, their peak aerobic power can drop to 12 to 15 milliliter per minute per kilogram, which is quite low. So remember that when you're going to do an exercise prescription with heart failure patients. So as I said, fatigue, dyspnea, and reduced exercise tolerance are the hallmark of heart failure. So if we go with those kind of symptoms of heart failure, well, there's this classification that's called the NYHA classification for heart failure that kind of quantify or classify your heart failure patients. So it's based on the degree of breathlessness of the individual. So the NYHA class focused on exercise capacity and the symptomatic status of the disease. So it's widely used in clinical practice. You'll most often see this classification if you're working with heart failure patients. And it's also used in research, so in clinical practice, as I said, to determine the eligibility of your patient for certain healthcare services. But in our case, it's going to be used for exercise prescription. Because what will happen is that you'll classify your heart failure individual according to this classification, and you'll prescribe your exercise intensity depending on where your patient is in this classification. So what it says, so basically there's 4 categories, 1 to 4, and the 1 being that the individual is least limited. So that person would have no limitation of physical activity. They're the one that we would consider the most in shape, let's say. So doing ordinary physical activity would not cause any symptoms of heart failure, which I said was like fatigue, decreased exercise tolerance, and breathlessness. So as we move along those 4 categories, the condition of the individual is getting worse and worse. So the 4th one is that the person is unable to carry on any physical activity without symptoms of heart failure. Or the symptom of heart failure even exists when they're at rest. So they'll have shortness of breath even just standing or sitting. So remember this classification as we will reuse them in the exercise prescription. So you might be wondering, with all I've just said, the consequences, the symptoms, should these people really exercise? Should they just not rest and stay at home? Well, actually, no. Before, endurance training was delayed for 6 weeks after an event, but now we are prescribing exercise really soon after an event. It can be a week to 3 weeks, depending on the condition of the individual. If he or she has a stable condition, we can start the exercise pretty soon, and it is safe. But there are some things that you need to consider, so safety considerations that you need to take into account when you're going to work with this population. So this applies to CAD and HF individual as well. So you need to have written emergency policies and procedures when you're working with those individuals. You also should be trained in cardiopulmonary resuscitation. You need to be aware of that and know how to do that. You also have to have a sphygmomanometer and a stethoscope for intermediate and high-risk population, which I will describe a little bit later. And ideally have a defibrillator and oxygen, and not just have them, but know how to use them in a higher risk population, which I will describe as well a little bit later. All right, so I thought I should spend a little bit of time saying what the role of the kinesiologist was in terms of the core competencies when working with higher risk conditions. And this doesn't come from my own opinion. It's according to research and articles, like what are the things that you should be aware of when you're working with high-risk population. So you should have an understanding and in-depth knowledge of many things you will see. So first of all, know the acute and chronic responses and adaptation to physical activity. So that you'll probably learn along as you're doing your kinesiology degree or with continuous education as well. The influence of medication on response to physical activity. That's something you might not learn so much, but you'll have to be familiar, especially working with higher risk population, the effect of medication on the exercise response and at rest. That's really important. Comorbidities. So today we're focusing on coronary artery disease and heart failure, but those individuals often have other conditions such as diabetes, obesity, which you have to consider when you're going to do an exercise prescription, because it'll bring some limitation or, you'll just prescribe your exercise differently. You have to know how to design and implement a safe and effective exercise that goes along. Diagnostic stress testing protocols and procedures. There's a lot of protocols out there. Some of them are more appropriate for medical centers. Some of them are more appropriate for gym, fitness centers. So you have to know which protocols you can do. Also, interpret resting and exercise 12-lead ECG. You might have to do that. You might not, again, depending on where you're working. But try to know a little bit of the basic, at least, so you know how to read them and know if there's a bit of something wrong. Also, risk factor stratification. I'll talk about this a little bit later. Very important in cardiac rehab. Also, know how to measure blood pressure. Contraindication to physical activity. There are a lot of contraindication to physical activity in those individuals. You might not be the one who says this person cannot exercise. The physician will probably say that, but try to be aware of what they are and what they mean. Also, when to terminate exercise training and testing, you're going to be the expert here, so know how to say, okay, enough, you're not feeling good, you don't look good, enough is enough, right? And as I said, for safety consideration, know cardiopulmonary resuscitation. So before we go into the initial assessment, it's important to know the phases of cardiac rehabilitation because the condition of the individual will change dramatically and hopefully for the best across only a couple of weeks, right? So you want to be aware of where your patient is at and if the condition has improved, and also depending on the phase, it will be based in a different setting. So basically the phase 1 is also called the inpatient program, and here the goal is to initiate the individual to starting to exercise. So usually the person doesn't feel too good on the treadmill, just starting to exercise. So, and this happened from weeks 0 to 4. Once the phase 1, and this phase is usually done in a medical setting, center, phase, so a bit more supervision, and you'll have probably a team of health professionals to help you as well in guiding this individual. The phase 2, or what we call the outpatient program, this is where your patient is starting to feel a little bit better. The goal here is really to improve the condition of the person, and it's a bit of a longer term, so from week 4 to 12. And yeah, so basically we want to improve the condition of the individual. The phase 3, now your patient is starting to feel more like Taylor Swift on the treadmill, hopefully starting to feel a bit better. And basically here what we want is we're focusing on exercise maintenance. So we want the individual to be an independent and confident exerciser that can keep the physical activity on a long-term basis, right? So it's from weeks 12 and after. So this one can be done in a medical setting, it can be done at home, in a community setting, or it can be a combination of all those different settings. Yeah, so basically those are the 3 phases. So be a bit aware of in which phase you're going to work and your patient is in. So now that we've covered a little bit, that was a long introduction. It was not just the introduction, but yeah, now that we've covered the condition and a little bit of your role, responsibilities, then we can start the initial assessment. So individuals should be assessed and advised on appropriate physical activity and exercise as early as possible within the rehabilitation process. So individuals should undergo a physical activity clearance and an assessment prior to undertaking the physical activity program. So you might be involved, you might not be involved in the initial assessment, depending on which of the phases that you are. But even if you're not doing the initial assessment, you need to understand how they're carried out and what are the results from those assessments, as this is what will guide your exercise prescription, right? So here I'll cover the aerobic exercise testing and how to stratify your patient. So I said earlier that I would talk about risk stratification, so we'll talk about this here. And basically what the initial assessment is what will guide your exercise prescription. So the aerobic exercise testing, or what we call the symptom-limited exercise testing, provides really important information in the development of an effective exercise prescription for patients with cardiovascular disease. So basically, it can provide information that can be used to formulate a diagnosis or prognosis, but our particular interest here is for judging the risk of exercise participation and to formulate the individualized exercise prescription. Also to identify the symptom, if the person has symptom when you're going to do the aerobic exercise testing, and the clinical responses that limit the exercise intensity as well. So basically, it's tested through graded exercise tests. We will not go through all the protocols because there is a lot out there, the Bruce, the ramp. But basically, what you want to do is most likely a constant increment protocol instead of something that is non-linear. And yeah, there's a lot of resources out there if you're looking for protocols. If you look at the ACSM website or even the CSEP, I think they have guidelines on which protocols to use depending on the condition of your patient and what you're looking for. Yeah, so basically it provides important information on the risk of cardiovascular disease-related events as well, and premature mortality. So it's important when stratifying your patient with cardiovascular disease. For example, in order to know if the person has low peak power and low cardiorespiratory fitness, right? It also serves to promote client confidence and reassurance that routine activities can be undertaken safely. So that's one of the objectives as well of aerobic exercise testing. All right, so let's move on to, as I said, it's important to stratify your patient in what risk category he is in before prescribing the exercise prescription. So we will not go with through the PAR-Q, but let's say you have a positive response from the PAR-Q, so you know that the individual has cardiovascular disease, or heart failure or arrhythmia. Well, now you've done the aerobic testing that we've just talked about. Well, the next step is to be able to classify in which category your patient is. What this will tell you is what intensity and degree of supervision you'll need to apply with this individual. So basically this tool helps the exercise professional to identify relevant information for individual management, appropriate levels of supervision and monitoring. It focused on ensuring that the patient has appropriate follow-up in addition to determining their risk of exercise-related adverse event. So basically it looks like this. So you've got the lower, intermediate, and higher risk. So as you go to the higher risk arrow, basically, you will decrease the exercise intensity. So if your individual is considered higher risk, you would prescribe some lower intensity exercise, and you would increase the supervision for this individual. Whereas if he or she is in the other side of the arrow on the lower risk, then you could increase the exercise intensity and decrease the exercise supervision. So what dictates if the person is lower, intermediate, or higher risk? How do you know that? Well, basically there are a couple of things that you need to look at. If the person is medically stable, if the person is physically active, if the aerobic power is over 5 MET, which you will have the data from your aerobic exercise testing, and if the person is 75 years or younger. So those individuals would be considered lower risk, so you can increase exercise intensity and they can have a bit less supervision. If you go to what describes an intermediate risk individual, well, again, they're medically stable. They are physically inactive, though. That's a change from the lower risk one. Their aerobic power is unknown. They're a bit older, so older than 75 years of age. And here we add a category for heart failure patient. You've noticed that in the other category, the heart failure are not there, because they are considered intermediate risk. The heart failure patients are never in the lower risk category. So basically, if they are NYHA class 1 and 2, the classes that I described a little bit earlier, and an aerobic power of over 5 MET. So those are considered the intermediate risk population. Who are the higher risk populations? Well, the medically unstable, physically inactive, aerobic power unknown or smaller than 5 MET, diminished physiological function, and they have comorbidities, as I've described a bit earlier. And here, your heart failure individual are either class 3 or 4, so the ones that are quite less healthy, and class 1 or 2 that are not currently active. So basically, if you follow a bit of this continuum, you'll have a good indication of how to prescribe your exercise intensity and the level of supervision that you need to apply in those individuals. Also, what this does is the lower one, in the lower category, they can be cleared for physical activity without the physician. So basically, you've got the knowledge and you are able to prescribe an exercise intensity without having the physician's clearance. So that's what it does. Whereas the higher risk spectrum, you still need that clearance to say, hey, this person can exercise, but needs a qualified exercise professional to be working with this individual. So what this does too is also that it reduces barriers to physical activity, because you know that the lower risk individual, you'll be able to take charge and start the exercise prescription. So basically there are 3 factors here that you need to remember that are consistent across the 3 categories. So the medical stability, if they're currently active, and their aerobic fitness. So those are the 3 main ones that you got to remember. So what else to consider before starting the exercise prescription? All relevant medication, I talked about that. It's your role to know a little bit about the medication for kinesiologists. Basically, that's a whole other topic that we could talk about for a couple hours, but you need to know the effect of medication on the heart rate, the blood pressure, and the exercise capacity. So once you know about that, you have a good idea of the relevant medication effect on the exercise. All relevant signs and symptoms, if the person has angina, dyspnea, arrhythmia, if the person is too tired, has excessive fatigue, weight gain, like recent weight gain in the past week, or weight loss as well, that's important to know. Comorbidities and mobility issues. You need to know if the person will be able to work on the treadmill or on the bicycle because of mobility issues. And physical measures as well. That's a bit of a given. You should do that with healthy individual as well, like weight, BMI, heart rate at rest, and blood pressure as well. So now that you've got all your information, you've done your initial assessment, you've got the results from the aerobic exercise testing, you've got the physical activity clearance, you know the individual in which risk category he or she is in, then you can start the exercise. Finally, you're ready to do the exercise program. So basically, it's not big news here, but all programs should include a warm-up, a conditioning phase, and a cool-down. And the conditioning component should be designed to produce a training effect achieved by setting and progressing to appropriate frequency, duration, type, and mode of exercise. So your FITT principle here. So although the same principle for exercise training apply for all individuals, there are special consideration and adaptation for CAD and HF individuals. So the goal here during your exercise program is that the individual should receive ongoing education on how to exercise safely and effectively. As I said, because in phase 3 we want to have someone who's confident and someone who will be more independently able to do the exercise, because we want that person to keep exercising for the rest of his or her life, right? Yeah, so basically another goal too is to help the patient return to the quality of life that he or she has before the event. And you have one advantage here in cardiac rehab is that usually the patient is motivated to start the exercise program. They're usually, they're motivated to start and to get better. You're starting at a good point here. So if we start with the warm-up, so low intensity graduated warm-up is essential to prevent 2 things, ischemia and arrhythmia. We want to prevent this with the graduated warm-up. So basically we ensure that the heart, the coronary arteries, the conductive tissue are all ready to meet the metabolic demand of the exercise prescription. So yeah, you create sufficient blood flow, ensure that the key organs are optimally prepared for the controlled stresses of an effective exercise session. So the goal here of the warm-up is to increase the ischemic threshold, so when the person starts having a bit of pain, prevent unnecessary fatigue or postural instability. We want to prevent muscle and joint injuries. And it's also a good time for the kinesiologist to assert the exercise technique if the person is exercising properly. So by the end of the warm-up, you should have reached a max of 40 to 50% of peak capacity, so quite low. Heart rate within 20 beats per minute of training or target heart rate, which I will define a little bit later. a maximum of 40% of heart rate reserve, which is your heart rate max minus your heart rate at rest, and a rate of perceived exertion of less than 11 on a 20 scale, on the Borg scale. So let's go ahead with the conditioning phase. So you know that all the individuals are pretty heterogeneous, so exercise training must be individualized, especially at the beginning of the program, to have optimal efficacy and the lowest risk as well. So it's based on the FITT principle. You all know about it: the frequency, time, intensity, and type of exercise. So some of these 4 factors are pretty easy to personalize, not easy, but simple to personalize, depending on the patient, on the condition of the individual, and the fixed objectives that you will have. So in terms of frequency, it's going to be from 2 to 5 sessions a week, so depending again on which phases of the cardiac rehabilitation you will be in. A duration from 30 minutes, and it can go to 2 hours if you want, if the condition of the individual is good. In terms of type of exercise, today I will focus more on endurance training, because we know that continuous aerobic training remains the cornerstone of cardiac rehabilitation. It's widely recommended by guidelines, and it's applied across the globe. But with that being said, I'm a big advocate of resistance training, and I know it's really important, especially in older individuals, so don't hesitate also to prescribe resistance training in your program, in your exercise. So basically, I've talked about frequency, time, and type. So it's the intensity of the exercise that is the least standardized in cardiac rehabilitation. So the exercise intensity can range from 40 to 80% or even 95% if you're doing high intensity interval training. You can go pretty high in terms of intensity. So I will focus a little bit more on that. So you probably know that there are different variables that can be used to prescribe intensity, such as the peak power output, percentage of VO2 peak. You can even use the rate of perceived exertion, so your Borg scale, to prescribe your intensity. But today we'll focus a little bit more on the heart rate, because that's probably what you're going to use first. So how do you determine the target heart rate? So the exercise intensity that you're going to prescribe to your individual. How are you going to determine that? Well, first of all, you need to measure your resting heart rate. I think you're all able to do that. We'll not go in too much details on that. The second step is to determine a maximum heart rate. So how do you know the individual's maximum heart rate? Well, you can do, as we talked a bit earlier, the symptom-limited exercise testing. That's going to give you the true heart rate max. But unfortunately, you might not have access to that. You might not do the symptom-limited exercise testing, or you might work in the phase 3 cardiac rehab, and you do not have access to the individual's files, so you do not have that heart rate max. So what do? You can use an age-estimated formula. Even in cardiovascular disease, people that have cardiovascular disease. But please do not use 220 minus the age, because that's not going to work out with those individuals. So first of all, you need to account for beta blockade. So you'll need to subtract 30 beats per minute to your target, to determine your heart rate max. Then there are 2 equations that you can use, the Inbar equation and the Tanaka equation. You can see here that they're much different than your 220 minus the age. If you're working with HF individual, you're going to have to use the Kinesiology, I have no idea if that's how you pronounce it, the formula for beta-blocked HF individual. So this regression equation already takes into account that the individual is using beta blockers, so you do not have to subtract your 30 beats per minute. So those formula will help you in determining the heart rate max. Once you have that, you can use the Karvanen method to determine the target percentage of heart rate reserve training zone. So basically what it is, it's your heart rate max minus your heart rate at rest, that's your heart rate reserve, times the percentage required. This is where you'll use your skills and knowledge and see where your patient is at to prescribe an exercise intensity that's appropriate for the individual. Like I said, it can range from 40 to 80%, depending on a lot of different variables. And then you're going to add your heart rate at rest. So this is going to help you in determining the target heart rate. So let's do a little bit of equations here, because we all like math. So we're going to do an example. So let's say you're deciding that the individual will be doing 40 to 70% of heart rate reserve. That's your target heart rate training zone. The individual is on beta blockers, but you do not have the results from the graded exercise test. So Scarlett is 60. She's going to start working out, and you have her heart rate at rest that is 50 beats per minute. So let's try to determine the target heart rate here. So basically, if we use the in-bar equation, we will have a heart rate max of 165. We will subtract the 30 because the person is on beta blockers, so we get to 135 for the age estimated heart rate max. Then you're going to use the equation. So if we go step by step to calculate the heart rate reserve, you do 135 minus your 50, so that's your heart rate max that you've just calculated, minus your heart rate at rest, it gives you 85. And then you will select your percentage of heart rate reserve. We've said that we want to achieve between 40 and 70% of intensity, so that'll give you 30 to 59.5. Don't forget to add your resting heart rate, so you get to 84 to 109. So basically, your target heart rate result will be from 84 to 110. So once you've determined that target heart rate, then it's much easier to educate the individual on what intensity he or she can start the exercise. And we've had really good result when I was doing my master's degree in educating those patients and saying, okay, you are going to work from 84 to 110 beats per minute training exercise. And they were really able to take their heart rate. We were educating them on how to measure their heart rate. And even if it was in a group setting or an individual setting, they were able to take their heart rate and really be within this range of intensity. So that's something that's really feasible, and that's also recommended. I just want to show you a little bit of this table because I think it's quite helpful, because I told you that the exercise intensity, that you have a big range that you can go from 40 to 95%. So this table was published by GAIDA in this year, in 2016. I'm a bit biased because that was my master's supervisor, so I kind of follow what he's publishing. So this one is quite a good table. So basically, based on your patient profile, so that first column that you have here, and this is what I described a little bit earlier, so in which NYHA category your individual is, and if he's got low or higher function, and then based on the phase, if he's in the initiation, improvement, or maintenance phase, you have kind of a guideline here on saying, okay, which intensity does the individual need to be working out? So is it 40, 70%? And then there's also guidelines on if it should be continuous aerobic exercise or high intensity interval exercise. So I will not go through all those numbers, but basically know that there is such a table available that will kind of guide you in which intensity to tell your individual to work at. So recovery. You do not want to skip this step if you're working out if you're working with cardiovascular disease individuals. So the risk of hypertension, ischemia, and arrhythmias within the first 30 minutes after stopping the exercise is well documented. So a graded cool down has been found to reduce the incidence of those complications. So basically what you want to do is return to near resting level within 10 to 15 minutes after your conditioning phase. You want to supervise the individual. Don't let them do their cool down and not supervise them. It's really important to have an eye, even if it's in a group setting, individual setting. You want to monitor the individual during the cool down. Unfortunately, when I was at the Montreal Heart Institute, we had one cardiovascular event, and it happened in the parking lot after the individual was done the training session. So unfortunately, this is what happened. It's usually in the recovery phase, after the exercise training. So don't underestimate the recovery period. It's a really important phase of cardiac rehabilitation. So it should be, like I said, a minimum of 10 minutes of really moderate exercise. You can incorporate stretching, the flexibility component as well in the recovery period. I'm almost done here. What to monitor during exercise. So there's a couple things that you should monitor. As I said, the heart rate response. You can educate your patient on how to monitor their heart rate. So that's something that you can do at the beginning, but then let the individual take responsibility of their heart rate if you educate them properly. Also, blood pressure, as I said, ideally take it before and after, especially in those first phases of cardiac rehabilitation. If you have a drop in blood pressure during the exercise, you need to decrease the intensity, very important. Also, this will be your best friend. The Borg scale, you will use it, make sure it's always in view, because you need to educate your patient as well on how to use it. And once they get better, they will know which target heart rate corresponds to the Borg scale. So you'll be able to prescribe your exercise intensity with the target heart rate and with the Borg scale as well. And finally, always observe your participants, your individual, to make sure that they are not dizzy, that they don't feel good, that they sweat too much. So really be observant of the individual. Also for safety, for excessive fatigue. So what now? So basically, what I want to say is that with all your experience, clinical judgment, and also focusing on those core competencies that I've mentioned, you will be able to do a great initial assessment and then do an exercise prescription that's really individualized to those individuals. And basically that's it. And I've got a couple of recommended references because it's a big topic to cover in 45 minutes. So if you have more questions, you can always refer to those references. They're great resources. So thank you for your attention. So as I mentioned, you can email bemister@sfu.ca if you have any questions about the presentation. We have 10 minutes.
Will your slides be available in EAT?
Yes, we will make them available in a couple of days on the BCAK website.
Yeah, they'll be in the members section.
Okay. Because that would be helpful for the references.
Yeah, exactly. That's why I thought it would be a good idea to make them available.
So far, no questions.
I have one.
You have one.
Do you treat people with single vessel disease different than people with multiple vessel disease?
Single vessel disease instead of multiple vessel disease?
For single vessel disease for atherosclerosis?
Oh, that's a good question. I don't know in terms of guidelines if you should treat them differently. I'd have to look that up. But single vessel disease instead of multiple vessel disease? Based on the initial assessment, depending on the condition of the individual. Oh, that's a good question. I don't know in terms of guidelines if you should treat them differently. I'd have to look that up, but single, so very low.
Yes. So he was, and you couldn't push him. So you should see with your exercise test, it's going to go up.
Guidelines if you should treat them differently. I'd have to look that up, but single. It's very challenging because their heart rate will not go very high.
So you should see with your exercise
that's why it's important. Like I focused on target
guidelines
medication, but in those individuals as well, because of their medication, you need to go with power output with the percentage of not go their rate of procedure. And that's why it's important. Like I focused on target
guidelines
medication, but in those individuals as well, because of their medication, and you need to go with power output with the percentage of because of that. Because at one point they will push, but the heart rate will not go fast enough, and they'll start not feeling too good.
Slows recovery. You don't get that after effect. Recovery takes a long time.
Yes, that's important. The long recovery too, because of that, right? Any other questions?
Not yet.
Good.
Can you tell us more about the facility you're working at in Kinesiology?
Oh, I work, the non-for-profit organization is, they provide education and training for Aboriginal and non-Aboriginal. So basically, I was hired there at first to do medical assessment, so functional capacity evaluation for them. But as you're aware, all the LNG projects are on hold right now, so there's not that many people coming in town. So I don't do that much functional capacity evaluation anymore. So I help them with the funding application, so it's more on the computer type of work right now. But so as a consultant, we're trying to develop a phase 3 cardiac rehab in Kitimat. Because what happened is that it's a small community, right? So they have all those patients that have had an event, or it can be a cardiac event, but diabetes, obesity, and they're taken in charge in the hospital setting. But there's no other facility to take care of them once they've done the first phases of the cardiac rehab or just rehab in general. So now we're trying to do a continuum where we'll take those individuals in the community setting. So that they stop exercising in the hospital setting and that they start using the facilities in the community. So trying to do that right now.
And you mentioned research with your supervisor. Was that your supervisor through your PhD?
Well, the last year of my PhD, I did an internship in North Carolina.
So at that Wake Forest?
Yes.
I'm just seeing it on your profile.
Yeah, exactly. So basically, I kept collaborating with this, her name is Barbara Nicholas. So what she does is she gives me like data, and we're looking at how we can publish article with all the research that
from
she
Wake
does.
Forest?
Yes, she's working there.
How did you land there? That's such a small. This was looking at it.
It's, well, because I was looking, when I was doing my PhD, I was like, okay, who does something similar that could kind of align with my thesis? And there was this lady in Wake Forest that kept doing the same research, but 2 years prior to
you.
Yeah. So like, okay, she knows what she's doing, and so I just contacted her and said, hey, I got 4 months, I've got a bit of money that I got from the government, can I come to your lab? You don't have to pay me, basically I just want your knowledge and supervision.
Okay.
And so she guided me throughout those 4 months, and I really developed a good relationship with her, and we keep collaborating because of that now.
Okay, good.
Yeah. She knows it's important for me to keep publishing as well, and it's a good way for me because Kitimat is far, right? It's hard to be involved in a university, and so.
Did you go to Kitimat for the job that you're doing now?
Physical.
Yeah.
Yeah, he got hired. Because we finished a little bit. No, I finished before him. He finished before me. Sorry. And we said the first one who's got an opportunity out of Quebec we're going to go with that. So he got an opportunity, and
I mean, it's a nice place to live.
It's awesome. It's
Beautiful
really
place
good.
to live.
Yeah.
I'll just check.
If you like the outdoor activities and nice mountains.
So once you moved away from cardiac, although you're still doing it, but you've developed specific expertise now in something else. What do you usually work on now with the articles?
Oh, it's more, yeah, because for the master's it was more in heart failure patient, coronary artery disease, like I presented today basically, but now it's more in obesity prevention and treatment, the effective exercise in obesity, and yeah. But it all aligns kind of together.
Oh, and when you said resistance training, I'm assuming that's weight training as
Oh,
well as...
yeah.
Right, okay.
You don't use that same terminology?
I don't. What do
Yeah?
you use? Do you say resistance training?
I use resistance training.
You use resistance
The
training?
younger group might use weight training.
Yeah,
If you want to relate to the gym-based people,
weight
you're
training.
talking weight training.
Okay.
Because it's not just the resistant band.
Right.
That's what I was thinking of.
Yeah.
I'm on track then.
It's basically a public sale. If you want to use resistance training for the older population that doesn't like the idea of going to the gym.
Right. I didn't even think about that,
Right.
but it's right. Yeah, there's a lot of
So we're going to wrap up soon. If we do have any questions, they can actually send them to the BCAK office, and then we'll have them redirected to you.
perfect.
If something comes up with anything afterwards for that, and if anybody needs a continuing education certificate, they can also email the BCAK office, and we'll have one of those sent out to you.
Awesome.
Okay?
Great. Thank you very much.
Thank you for coming. Dr. All, thank you.